Welcome to The Explainer. Today we're jumping right into three huge cardiovascular emergencies that you've got to get right. We're talking about a sudden blockage that can choke the lungs, an immune system mistake that attacks the heart, and a sneaky infection that chews through its valves. Knowing the difference is everything, so let's break it all down.
So here's our game plan for today. We'll kick things off by introducing our three conditions. Then we're going to do a deep dive into each one, from the why it happens to the what you do about it. And to wrap it all up, we'll put them side by side so you can really nail down the key differences.
Okay, so we're looking at three totally different dangers to the heart and lungs. But where do they come from? Well, you can think of it like this. One is a straight-up plumbing problem. Another is a case of mistaken identity by your own immune system. And the last one? That's a full-on microbial invasion.
First up, let's talk about pulmonary embolism. This is a true mechanical crisis. It often starts way down in the deep veins of the legs, super quiet, with a clot that decides to pack its bags and travel straight to the lungs. So just imagine this for a second. A piece of that clot breaks free. It's now an embolus, and it's cruising through the veins, up through the right side of the heart. But what happens when it hits that roadblock, the narrowing pulmonary arteries? It's not just a simple blockage. It sets off this sudden dramatic chain reaction that can be absolutely catastrophic. And here's exactly how that collapse happens, step by step. It all starts with that clot. When it gets lodged, it's like building a dam in the pulmonary artery. The pressure behind it skyrockets. And the right ventricle, which is not built for that kind of pressure, starts to stretch and fail. Suddenly, the left ventricle isn't getting enough blood. Cardiac output just plummets, and the whole system can crash right into shock.
So who's at risk for this? Well, we have a classic model for that, Virchow's triad. You just have to think about three things. First, is the blood flow slow and sluggish? We call that stasis. Second, is the blood itself just too sticky, too prone to clotting? That's hypercoagulability. And third, has the inside of the blood vessel been damaged, maybe from a recent surgery or trauma? If you've got one or more of these, the risk of a clot goes way, way up.
Now, what's really important to get from this slide is how we categorize these patients. It's not just about how big the clot is, it's about what it's doing to the patient. Are they in shock? That's a high risk or massive PE. Are they stable for now, but an echo shows that the right ventricle is really struggling? That's intermediate risk. This classification is everything because it tells us exactly how aggressively we need to act.
Okay, we just covered a mechanical problem. Now we're going to switch gears to something totally different, a case of friendly fire. Rheumatic fever is what can happen when the body's own defense system gets confused and makes a terrible mistake after something as simple as a strep throat. And this whole disease really boils down to one core concept, molecular mimicry. Think of it like this. Your immune system's facial recognition software goes wrong. It creates these amazing antibodies to fight off the strep bacteria's M protein. But the problem is, certain proteins in our own heart valves, joints, and even our brain look just similar enough that those same antibodies start attacking our own tissues. It's a devastating case of mistaken identity.
So how do you diagnose this? Well, you can't just rely on one lab test. You have to be a detective, and your guide is the Jones criteria. What you need is solid proof of a recent strep infection, plus a specific combination of signs, either two major ones, like inflammation of the heart or that classic migrating joint pain, or one major and two minor signs, like fever or high inflammatory markers.
And when rheumatic fever goes after the heart, it doesn't mess around. It can cause something called pancarditis, which is an attack on all three layers. You get endocarditis, hitting the inner lining and valves, which can cause permanent damage down the road. You get myocarditis, inflammation of the actual heart muscle, making it weak. And you get pericarditis, inflammation of the outer sac, which causes that sharp chest pain. It's a total all-out assault. All right, our third and final threat. This is where the microbes don't just trigger a reaction, they move in and set up camp. Infective endocarditis is a direct, destructive infection on the inner lining of the heart, usually right on the valves themselves. The hallmark of this disease is something called a vegetation. And this isn't just an infection, it's more like a little fortress. It's a clump of bacteria, platelets, and fibrin all stuck together. This nasty little ball grows right on a heart valve, physically destroying the tissue, and even worse, it can break off, sending little infected clots, septic emboli, to the brain, the kidneys, anywhere. So how does this fortress get built? It's a multi-step invasion.
First, you need some kind of small injury to the lining of the valve, which creates a little rough patch. On that spot, a clean, sterile clot can form. Then, if bacteria happen to get into the bloodstream, say from a dental procedure, they can find that clot, grab on, and start to multiply. And just like that, they've started building their destructive colony. Okay, here's a really common point of confusion: endocarditis versus myocarditis. It is absolutely critical not to mix these two up. Endocarditis is a bacterial infection on the valve. That means you'll usually get positive blood cultures, and on an echo, you're looking for those vegetations. Myocarditis, on the other hand, is inflammation of the heart muscle itself, often from a virus. Blood cultures are usually negative, and you're looking for things like a high troponin. Two very different problems.
So you've got them on IV antibiotics, but when is that not going to be enough? A huge part of management is knowing when to call the surgeon. And you've got to do it if the valve is so damaged it's causing heart failure, if the infection just won't clear up or forms an abscess, if there's a big vegetation that's about to cause a stroke, or if the valve itself has literally been torn open. Okay, let's bring it all home. Imagine a patient comes in, they've got a fever, chest pain, they're short of breath. How in the world do you tell these three critical conditions apart when it really counts? Think of this slide as your mental cheat sheet. For a PE, your brain should scream sudden shortness of breath and mechanical obstruction. For rheumatic fever, think recent strep infection and migratory arthritis. It's an autoimmune problem. And for infective endocarditis, think fever, new murmur, and direct infection. You need those positive blood cultures. Each one has its own unique fingerprint and its own diagnostic criteria. You know, the one thing that connects all of these, whether it's a clot, an antibody, or a bacteria, is that if you truly understand the why, the underlying mechanism, the whole clinical picture just snaps into focus. It stops being a random list of symptoms and becomes a logical story. So the next time you're facing a really tough case, just stop and ask yourself, what is the fundamental process happening here? Because that's almost always where you'll find the answer.